Alrighty, we're just gonna wait a couple seconds as we let all of our attendees start joining us. And while we do that, I just want to say thank you all for joining us today. We're going to be doing a fantastic webinar. Again, some of you may be aware of this topic, and we're excited to have you on to discuss it further. It's the Canadian Consensus Statement on the Management of Venous Leg Ulcers, and we have a fantastic guest speaker with us today. But before I introduce him, I first just want to do a quick little icebreaker game. I can see that Shadi in the chat's already started. Please use that chat tool in your Zoom toolbar to let us know where you're tuning in from. My name's Troy, and I'm the Director of Operations of Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm tuning in from Ottawa here, and we're so excited to have you on. As you all know, we're going to be doing a Q&A portion at the very end of this, so we encourage you to use that Q&A button, not the chat button, but the Q&A button in your Zoom toolbar to ask questions throughout the presentation. That'll make sure that Dr. Stacey and I will be able to get to that towards the end. It is being recorded today, so if you or your colleagues need to go review this after the fact, it will be available online, and those in attendance today will be receiving a certificate of attendance, so don't worry about that. So without further ado, I'm so excited to be introducing our guest speaker, who is here today on a courtesy of Perfuse Medtec, who we thank so much for being able to bring Dr. Stacey here. Dr. Stacey is the lead of the Canadian Consensus Statement on the Management of Venous Leg Ulcers. A panel of 19 clinical experts from across Canada contribute to the project. And the Canadian Consensus Statement covers diagnostic approaches, therapeutic modalities, and ongoing care. Dr. Stacey is a vascular surgeon who arrived in Canada from Australia in 2014 and became the surgeon-in-chief at Hamilton Health Sciences and the professor in the Department of Surgery at McMaster University. He completed his medical degree at the University of Western Australia, is a fellow of the Royal Australasian College of Surgeons, and is licensed with the College of Physicians and Surgeons of Ontario. He spent 2 years working at St. Thomas's Hospital in London in the UK, where he conducted research for his Doctor of Surgery degree. Dr. Stacey became Chief Medical Executive and Executive Vice President Academic at Hamilton Health Sciences in 2018 until about mid-2023, and he continues his clinical work in vascular surgery. He's also a consultant for hospitals and biomedical companies in clinical practice, research, and physician leadership. As well as his more than 30 years of practice in vascular surgery, Dr. Stacey has established an active research program or multiple active research programs in wound healing in both Australia and in Canada. He was also the first president of the Australian Wound Management Association, which is now called Wounds Australia, and he's the founding chair of the World Union of Wound Healing Societies. So without further ado, I'm very excited to be passing over the slides and the microphone to Dr. Stacey. Thank you.
Great. Thanks very much, Troy, and welcome everybody, and thank you for coming and joining this webinar. So yes, as Troy has indicated, I'll walk through some of the background behind the Canadian Consensus Statement on Venous Leg Ulcers, and then the content of where that statement has got to at this point. There we go. Just quickly, sort of conflicts of interest. So I do, just to declare, I do have some current active consultancies with a couple of companies, as you see there, including Perfuse Medtec, who are sponsoring this session. I have had a number of consultancies and research collaborations with quite a few different wound care companies in the past, just by way of disclosure. So the objective of developing this consensus statement on the management of venous leg ulcers was really to try and incorporate new clinical research findings on the management of venous leg ulcers into that consensus statement. And it's really intended as an up-to-date practical guide for healthcare providers, really to enable them to use this as a really practical, short guidance tool for managing the patients who have venous leg ulcers. As Troy indicated, the key elements that are incorporated in this consensus statement are the clinical assessment, investigations, diagnosis, and then treatment, which centers around treating the underlying cause of venous leg ulcers, how to manage the ulcer itself, what options you have when the ulcer is not entering a healing trajectory, and then how to manage post-ulcer healing, how to maintain healing and try and prevent ulcer recurrences. So the key areas that are sort of a little bit new and haven't really been incorporated into guideline documents to date are in particular the new approach to improving calf muscle pump function using neuromuscular electrical stimulation of the common perineal, also known as Muscle Pump Activator. And there is a body of evidence on what this does physiologically. And then we saw a trial from Dr. Keith Harding and his team looking at how this actually improves healing in venous leg ulcers. And I'll speak to that study that Keith and his team did. In addition to that, we're also looking at a structured approach on how to deal with patients whose ulcers are not entering a healing trajectory. So what options are there for the wound care clinician? And in part of that is incorporating the principles around time, which all of you are probably very familiar with, something that's been around now for nearly 25 years. And a number of us were involved in the development of that sort of back in the late 1900s, early 2000s. So if we think about what we do to improve the calf muscle pump function, so really the primary cause of venous leg ulcers is an impaired functioning of the calf muscle pump. And that manifests itself as an elevated venous pressure when patients are walking. So normally when you're walking, the venous pressure in your deep venous system drops because of the action of the calf muscle pump. But when the calf muscle pump is not active, the venous pressure doesn't drop appropriately. And that leads to a number of changes in the microcirculation, including edema, tissue fibrosis, activation of an inflammatory cascade, and ultimately impaired healing. And I won't go into the detail of that. It's a complicated approach, which we still don't understand all of the elements of how that leads to impaired healing. But it's fair to say that even since the time of Hippocrates, the hallmark therapy for patients with venous leg ulcers has been to use compression therapy in some shape or form. And there is good evidence that that does improve calf muscle pump function and does help to reduce that elevated ambulatory venous pressure. What I think is really important is that there's been emerging evidence in the last few years of the use of the muscle pump activator, and that it has a significant role as an adjunct to compression therapy in treating patients with venous leg ulcers. What we know is that this improves the physiology in patients with venous leg ulcers, and also from the work of Dr. Harding and his team, this also improves venous ulcer healing. So just to do an overview of some of the body of work on how muscle pump activation or the muscle pump activator device improves venous physiology, there are quite a few studies demonstrating changes in baseline or from baseline in healthy volunteers. And what we see is that there is an improvement in venous volume flow, there's an improvement in arterial volume flow, and there's also an improvement in microcirculation. And from those studies, we know that using the muscle pump activator does improve the velocity and volume of blood up to 60% of what happens when you're walking. And that's without having to do any exercise. So it's really doing that while patients are at rest. And this slide just shows you, using laser speckle contrast imaging, what happens in a patient with a venous leg ulcer. So on the left at the baseline, you see the patient and you see what happens normally with blood flow. Just excuse me 1 minute. I've just got a dog in the room that's getting a bit restless. 1 second. There we are. My apologies for that. These interruptions when you do these things from your home office. But what you see on the left is the laser speckle. So you see that fluctuation with the normal pulsatile blood flow into the leg, and you see the paler area is the ulcer itself. What you see on the right-hand side, where you have the muscle pump activator device in place, significant increase in that venous flow in the area, not only in the ulcer itself, but in the area around the ulcer, so the peri-wound area. And the increase in the wound itself is about 225%, in the peri-wound area about 67%. And this is just showing that graphically. You see this increase in venous velocity, both in patients when they're recumbent and when they're seated, in the left-hand graph. And in the right-hand graph, this is just showing you the increased speckle pulsatility, both in the wound bed and the peri-wound area. So compared to baseline without the muscle pump activator device in place, there is a significant increase in venous velocity and also in the pulsatility of flow in the wound, in the peri-wound area. So we'll go on just to talk about the randomized controlled trial that was conducted by Keith Harding and his team. And this was really looking at a protocol for evaluating the wound healing intervention. And they used a slightly novel approach, which I'll touch on at the end of the presentation of his findings. But typically we've looked at area reduction, or percentage area reduction, as a way of assessing healing. In this study, Keith and his team looked at the rate of ingrowth of tissue or cells from the edge of the wound, which gives a more linear assessment of the progress of the wound. The nature of the study is really summed up in this slide. So this was a study where they initially recruited patients into the study and then entered them into a 4-week run-in phase where they all went into compression therapy. And you'll see through this study, there are a number of reasons for patients being removed or not lasting in the study, for various reasons, not meeting the randomization criteria, having other problems that required them to drop out of the study. But after the run-in phase, they had 60 patients eligible to go into phase 2. And the reason for doing the run-in phase is that they had, as a control, the patient's own healing rate without compression. Then after that 4-week run-in phase, they were randomized to continue on standard of care, which was standard compression therapy, or standard of care plus the muscle pump activator device. And they continued that for 4 weeks. This was applied 12 hours a day. Again, you'll see through the course of that, a few patients dropped out, but the majority of patients remained in both arms until the end of the trial. And then they're able to compare the performance with the application of the muscle pump activator in addition to standard of care compared to their performance with just standard of care. And in the standard of care group, they could compare how they progressed throughout the 2 phases of the study. As with most studies, when you're looking at different treatments, you want to know that your cohorts of patients that have been randomized to each group are similar. There are no specific characteristics that might prejudice in the performance in either arm of the trial. And you'll see here these parameters that were assessed. There was no significant difference between the 2 groups. And I think of note, if you look at the wound size, these were not small ulcers. The mean size was 10 square centimetres. And they're also ulcers that have been present for quite some period before they were entered into the study, which is both of these are factors that can contribute to delayed healing in wounds. And so we're seeing that, in both groups, these are patients with larger ulcers that have been present for longer periods. So nothing there to suggest that that should influence the performance in either group. When we looked at the patients who are randomized to just the standard of care, this is the performance in both the run-in phase on the left and in the treatment phase on the right. So this is looking at percentage area reduction. And you'll see there was a slight increase in percentage area reduction on the treatment phase, but not statistically significant. So effectively, no significant change in the percentage area reduction in the standard of care patients when between the first phase and the treatment phase of the study. When we look at those who received the muscle pump activator device, what we saw is a significant improvement in the percentage area reduction during the treatment phase in this group. And you'll see the significant p-value at 0.016, and certainly a much greater improvement in healing in this group when the muscle pump activator was added to standard of care compression. And this is just summarizing that again, but this is looking at what I mentioned before, that wound margin advance. So with that, when you do it that way, you get a much more linear approach. And if you look at that graph on the right, the healing rate between the two groups in the run-in phase was essentially the same. And what really happened there is that with the standard of care, it continued on that same trajectory. But with those who received the muscle pump activator device, the trajectory increased significantly to improved healing. So certainly this study has demonstrated that in these patients with venous leg ulcers, if you add the muscle pump activator device as an adjunct to standard of care wound compression for venous leg ulcers, that you do improve the healing rate. This is just some clinical examples, just showing you what happens to these wounds over the course of the 8 weeks. So these were patients in the top line that were receiving, or a patient who was receiving their standard of care. And then in the bottom line, this is when the muscle pump activator was added, and you'll see there's significant improvement over the course of that 4-week period. The second part of the consensus statement is also to look at how do we incorporate, an approach to some of the advanced wound therapies that we have, and incorporate the principles of time into a consensus statement on the treatment of venous leg ulcers. And some of these elements are not difficult, and I think all of you, have an approach to how to deal with this. So if we start with the two top ones, and I see I've put these back to front. So with the tissue, we do look at debridement of the devitalized tissue. That's an important initial step in the management of venous leg ulcers in the consensus statement. When we look at infection, so a big part of evaluating the patients at the beginning is to look at the presence of infection in the wound itself or in the surrounding tissue, and to treat that appropriately. Again, another part is to develop an approach to managing moisture in the wound. So if they're too dry, you try and keep them moist and retain moisture. If they're too wet, you try and wick away moisture. So principles that all of you, I think, are very familiar with. The part that I think many clinicians and indeed healthcare providers have struggled with is, what do we do with the advanced therapies, which really is that edge component where the edge of the wound is not progressing to closure as we would normally expect. And what we're providing in this consensus statement is a standardized approach as to how to utilize some of these advanced therapies in a structured way so that you address the underlying problems, you assess them, and then you respond to them appropriately. And it's based on this algorithm of advanced wound therapies that essentially what you do, if everything else is in place and everything else treating the underlying wound, you've assessed for presence of infection, you've debrided the devitalized tissue, you're using appropriate compression, and you're making sure that it's applied appropriately and the patients are tolerating it. As I said, you've managed infection. Then the next steps are to go through the key elements here. So one is biofilm and bacteria. So this is not actually talking about active wound infection. This is about managing bacteria that are encased in a biofilm, a protected biofilm on the wound surface. So the next step then is to look at using a dressing that actually does reduce or degrades biofilm and enables the bacteria to be then addressed by an antibacterial component. If the wound is still not healing with assessment, the next step is to go to doing something to reduce proteolytic protease activity. So you've got increased activity, you're trying to reduce that, and there are dressings available to do that. If you've addressed both of those things and it's still not improving, the next step is to see if you can improve the wound bed. And really the two key ways that we have to do that are both through negative pressure wound therapy, which you're all very familiar with, and also the use of matrix substitutes, which try and enhance and improve that wound bed that's required for the tissue, the epithelial cells in particular, to advance across to enable the wound to heal. If it's still not improving, then the next step is to look at how do we bring some growth-promoting factors to the surface of the wound. We don't have a heap of options for this at the moment, but there are some products that deliver growth factors in the constructs that can be used to try and bring growth factors there and promote further ingrowth of tissue from the edge of the wound. And if with all of that is still not getting advancement, then the next step is to go to adding new cells to the wound. And the assumption here is that the cells that are there are simply not sufficient to enable the wound to heal appropriately. And that might be by skin grafts, by cultured cells, by cellular constructs, or by some version of stem cells. So they're the key elements that we're looking to incorporate into this consensus statement. And I think the other elements we'll go through, many of you will be familiar with, but we're reinforcing that within the consensus statement. So just to sort of outline the process that was used for this, so the leads in this were myself, Gary Sibbald, Keith Harding, and Robin Evans. We enlisted a panel of 19 healthcare providers. We looked for people with experience in treating patients with venous leg ulcers, some experience with a calf muscle pump activator device, some experience with advanced wound treatments, and we looked at a broad spread of physicians, nurses, NSWOCCs, and some therapists across different jurisdictions in Canada. So the approach we adopted, we had a draft consensus statement that was developed in January and February of this year. We put that out to the panel for feedback. We then had a Zoom call with the panelists in March to discuss any particular points that needed discussion. We then revised the document and sent that out for round one agreement in March and April. We had further revisions of the document, sent it out for round two agreement in April and May. And then in this month, we finalized the consensus statement. It's in its final iteration at the moment. And that's what I'll be showing to you today. The goal in this process was to achieve at least 80% agreement from the panelists on each of the sections that we sent out for their consensus. And in that process, we had 100% consensus in 20 of the 23 sections. And in the remaining 3 sections, we had greater than 85% consensus. So really, broad agreement to the content of the document. And just to emphasize, this was done without any input from any wound care companies. So this was done independent of wound care companies. So this was all really the clinicians, the healthcare providers, feedback that developed and created this document. So these were the consensus panel members. You'll see a number of physicians there, and physicians come from different backgrounds, from general practice, from rehab medicine, dermatology, vascular surgeon, general surgeons. And then we have a number of others involved, mostly nurses. We have a occupational therapist. We have some with NSWOCC qualifications, some nurse practitioners, and some who are predominantly researchers. A good broad spectrum of clinicians, and we had excellent participation from them all in this process. So I'm going to go through for you the key components of the consensus statement, and some of this will be very familiar to you all, things that are really part and parcel of your practice. But we really started out with, the approach to the diagnosis of venous leg ulcers. So what are we looking at here? So we're looking at, the need to assess the cause of the ulcer, but also to understand other elements of the patients we're dealing with, their health literacy. How much do they understand what it is we're delivering to them? Environmental factors that may impact their ability to receive or to adhere to care, and their own individual goals of care. So needing to assess all of these things before proceeding to any form of treatment. And really just outlining, which will be familiar to you all, what's involved in that clinical assessment. So thorough history of ulceration, history of venous disease and arterial disease, specifically in this situation for venous leg ulcers. Then also understanding there are other medical conditions and other medications, because sometimes they can impact and impede healing in any type of wound, but in particular venous leg ulcers. And then examining the patients, looking at their ulcer, examining their pulses. And then obviously investigations that help us as clinicians to confirm or determine, what the underlying cause of the ulcer happens to be. Acknowledging that many ulcers have more than one etiology. So, even with venous leg ulcers, they may have combinations of arterial disease, they may have diabetes, patients may have other conditions like rheumatoid, etc., on top of having a venous problem. So we have to look at that, totality of the patient and their underlying conditions. The consensus statement describes some of the clinical features, which I won't go into any detail here. I think many of you are familiar with these, but it's around the location of the ulcers, which we know, it's predominantly in the gaiter region of the leg. Some of the typical appearances that we see in the wound and the tissue around the wound, and some of the elements that are there in that skin around the wound. And also the fact that a number of these patients have pain and the type of pain they have compared to perhaps an arterial ulcer, an ulcer that is predominantly of arterial origin. The next part of the consensus statement touches on the investigations, and here we try and provide some guidance to the healthcare providers as to what is it we need to do, what's the basic things that we need to do, what are the optimal things that we should aspire to do, understanding that not all of these things are readily available to all practitioners, depending on which part of the Canada you're in, and if you're in more remote areas or more rural areas, that some of these things are not readily accessible. The first is to diagnose venous disease, and to a large degree we do that clinically. However, we do look to have some sort of confirmation of the presence of venous disease, and to do that these days, the predominant method is to use a venous duplex ultrasound. And that's looking for presence of either occlusion of veins in the deep venous system, reflux in the deep venous system, or reflux in the superficial veins. It also helps us to determine if treatments like some form of surgical ablation may be appropriate at some point with these patients. However, understanding that there may be limited access to these tests, and if there are convincing clinical signs of venous disease, we do recognise that as long as we know the patient has an adequate arterial status, then it is appropriate to begin management, in particular with compression in these patients, while still awaiting to have that confirmation of venous disease. The second part is diagnosing other coexisting conditions, and really one of the major ones we need to be aware of is the presence of arterial disease. We do that in several ways, and again, being cognizant of the resources that are available to practitioners in different areas. One of the typical ones has been to use an ankle brachial pressure index, or if that is elevated, particularly above 1.4, and we see that in patients with diabetes, but also in some other patients with arterial disease and calcified arteries, then we look at a toe brachial pressure index, or actually just the toe pressure itself. So assessing that, and we're looking to see if there's a normal ankle brachial pressure index, so between 0.9 and 0.4, If it's elevated, we're looking to see if there is a normal toe pressure index or normal toe pressure. In some remote areas, or indeed, it doesn't have to be remote, but there just may not be ready access to getting ankle brachial pressure indices done. Another technique is to look at the audible waveforms on a handheld Doppler. So this is linked to a program called ECHO, which Gary Sibbald and his team has been running through Winpedia. And this is a simple way of assessing with a handheld Doppler and capturing the waveform or the audible waveform. And then there is an online evaluation process through ECHO to assess if that waveform is multiphasic. So we're looking at either triphasic or biphasic waveforms as against a monophasic waveform. And if you have biphasic or triphasic, it indicates that you've got a good arterial inflow. If you have monophasic waveform, it indicates you've got a poor arterial inflow and obviously need to have extreme caution or indeed to shy away from using compression in these patients until they're further evaluated. These days, the other ultimate way of assessing the arterial system is to do an arterial duplex ultrasound, which does give us a good indicator of whether there is significant arterial disease present and the level at which it may be present. And most vascular labs include with that the ankle brachial and toe brachial pressure indices as well. So they're the two vascular assessments that we look at. The other things there is to do, fairly standard things that you would do with most patients with any sort of chronic disease. So with a blood panel, you're looking at CBC, liver function, renal function, HbA1c, just to assess for underlying problems that could be contributing to impaired healing. We also, assess, do they have other conditions like rheumatoid arthritis, lymphedema, heart failure, renal failure, liver failure, all things that can impede ulcer healing. So need to be aware of that. As I mentioned before, with medications that they're on, they may be on some form of immunosuppression, but also can impede the healing process. So to be aware of all of those things when you're assessing the patient, the treatment, and then how they might respond. And the other thing that is unique to venous leg ulcers is assessing the gait and the movement at the ankle, as this may impair calf muscle pump function. So that itself, either with or without underlying venous disease, can lead to an impairment in calf muscle pump function. And this also leads to some of the treatment options that we have in these patients. So when we go on to the treatment of venous leg ulcers, so the key part of the treatment is to treat that underlying cause of impaired calf muscle pump function. As I mentioned to you before, the mainstay of treatment has really been to use compression on the leg. And we would ideally look at applying an optimal compression system, and in most cases that'll be a multi-layer bandage system trying to achieve between 30 and 40 millimeters of mercury of pressure at the ankle. We do that if we know that there is normal arterial blood flow. So the way we assess that, if the ABPI is between 0.9 and 1.4, or if the ABPI is elevated, but the toe pressure or the toe brachial pressure index is normal, then we're comfortable applying it. And if our only access is a handheld Doppler and we know we have a multiphasic waveform, which indicates there is good arterial inflow, then we're comfortable applying optimal compression. As I mentioned, the common compression is a multi-layer bandage system, but there are other systems that can be used, and there are elastic and inelastic bandages. There are adjustable wrap systems that have hook and loop fasteners. There's intermittent pneumatic compression, which is probably more applicable to patients who are somewhat more immobile. And then there's the use of other compression socks. And what's important is that we assess, what is suitable for the individual patient based on their mobility, based on pain, We may have to delay the compression or reduce the compression if they have a lot of pain. Based on their individual tolerance, their ability to apply the compression, the environment, and indeed even their access to the compression systems. The second component in terms of improving calf muscle pump function is to encourage calf muscle contraction exercises. And a common way of doing that is to look at a daily walking regimen to improve calf muscle pump function. However, other patients who have limited ankle motion, limited strength, limited mobility, or have an impaired gait, then we may be bringing in the support of our colleagues in physiotherapy or rehabilitation medicine, and also looking at daily elevation of the leg above the heart to try and reduce the pressure and also reduce the edema in the leg. So, but those are important things to add to patients who have compression applied, and also, we adjust that according to the other conditions that may be present that might be impairing their calf muscle pump function. Question then is, so what if they're not able to tolerate optimal compression? So what are our options? So here, if the ABPI is reduced, but still greater than 0.5, or alternatively, if the patient has significant congestive cardiac failure, which we've got to be careful of applying compression, then we look at some form of lower compression. Where the ABPI is less than 0.5, we would not normally apply compression, without having a vascular surgeon involved in that patient care. So the way of looking at compression is to look at some form of lower multi-layer system that the patient will tolerate. And ultimately, if possible, to progress to an optimal compression system if their tolerance will allow. Now, some patients still have normal ABPI but can't tolerate the higher compression, so we go to the lower level and then see if we can work back up to that ultimately. But when their Dopplers are reduced, when their ABPI is reduced, so if it's between 0.65 and 0.9, or if it's between 0.65 and 0.9, then we look at these lower level systems. We do that with caution. But we have extra caution if it's lower than 0.65 but above 0.5. And that's when we would suggest just using some form of stocking it, either a tubular or longitudinal compression, rather than using compression wraps in those circumstances. As at least some form of compression, it's better than no compression at all. And then the additional thing, because we're not able to go to an optimal compression system to optimize the calf muscle pump function, then we know we have the option of adding the muscle pump activator. And this is a good indication for using that. And what this is doing, it's an adjunct to the lower level of compression that we're utilizing, understanding that this is not a compression system, so it's not replacing a compression system, but it's being used as an adjunct when we can't get patients into optimal compression. And indeed, even in patients with low arterial ankle brachial pressure indices or with arterial problems, there is a role for muscle pump activator in those problems, those patients to improve both their arterial and venous flow. And then patients who are not able to tolerate any form of compression due to pain or other causes, then for certain the use of the muscle pump activator, it's the only tool we then have to improve their calf muscle pump function. And certainly, is an option we have to do something when we're not able to do anything with any form of compression. And just reiterating, we do this with all patients to look at regular exercise and where appropriate to elevate their legs. We reinforce in this group, to do that as we do with all groups, but still something that should be reinforced, particularly with this group. We then go to treating the venous leg ulcer itself. So this is really, what do we do with the wound? So here we come on to wound management, which is a big part of what you all do. So the simple things, cleansing the wound, and they're again in different locations. You may have access to saline, you may not. You may just use potable water. But if you do also have access to an antimicrobial solution such as hypochlorous acid, this also helps to reduce bacterial contamination. As I mentioned before, we look at the debridement component if there is devitalized tissue, so that T component in the time paradigm. And so here we have various methods available to us, and the method we use depends on the scope of practice of the individual, the skills and the experience of the healthcare provider. I won't go through the details of each of these, but you can see the different methods that may be used there, including sharp debridement, which could be, under anesthesia if necessary, or conservative sharp debridement without local anesthesia. But obviously, we want to try and remove that devitalized tissue to bring that that wound bed back to a healthy state. Then the other component that we have also is the addressing the moisture component, so the other part of time. And here we're using a dressing that will either keep the wound moist if it's dry, or if it's too moist, we'll wick the moisture away to stop it being overly moist or macerated. So that's where you have a choice of dressing to help with that. We assess the infection and we treat any infection that we can identify in the wound itself or in the surrounding tissue. And if we've identified infection, we have a combination of antibiotics and some antimicrobial dressings or cleaning solutions such as hypochlorous acid. We manage pain, and here we may have to delay compression, as I mentioned before, if the patient has significant pain. We need to treat the surrounding skin, just simple principles of maintaining good skin care. If the skin is irritated or has dermatitis, then we need to treat that. We need to protect it from excess exudate. In ulcers that are deemed to be non-healable, again, we're looking at just trying to provide a maintenance treatment for these patients, and obviously use appropriate dressings to support the patient's maintenance goals, and cleaning the wound to try and minimize infection with a saline potable water or an antimicrobial solution. Then one of the other key elements in treating the ulcer is measuring it. And there are different measuring systems that are available. It may be simple ruler measurement, it may be a tracing, it may be one of the enhanced measures that you can do over a cell phone. It may be using a device that can also measure the wound. Whatever it is that you have available, we strongly recommend measuring it weekly. If they're seeing less often, then at each visit. So then you can track what's happening to the wound, because that helps to determine next steps if the wound is not, entering a healing phase. So the next part of the consensus statement talks about what is happening that's not reaching a healing trajectory with no size reduction in 2 to 4 weeks or less than 30% at 4 weeks. Very first thing is to review the diagnosis. Have we got the diagnosis right? So go back and relook at, the parameters that we detected clinically on history, examination, and investigations. We then also need to assess if their treatment protocol with compression is being properly implemented and adhered to, and reassess if there is infection, if there is, if it's being appropriately managed. If all these things are in place and they're appropriately, we've got the appropriate diagnosis, we're looking at no infection or it's being well managed, as far as we can tell, the compression is appropriately implemented, then we need to go and just reassess the treatment of calf muscle pump function, reassess the compression system. Is it the optimal system we could use for that patient? Review the exercise and walking regimen. Is that appropriate? Have we got that in place? And the additional thing here is to add the muscle pump activator device if it's not already in place. But if it's not following an improvement trajectory, or entering that improvement pathway, then there is a significant role for improving calf muscle pump function by adding the muscle pump activator device at this point if we haven't done it already. And one other thing that sometimes gets forgotten is if the venous duplex ultrasound has indicated just superficial venous disease, should we refer that patient for appropriate superficial venous ablation? This could be a time that might be the simple thing that will help improve healing. And if we've done all of that, we've optimized the calf muscle pump function, added muscle pump activator, and the wound is still not healing, that's when we consider the advanced wound therapies. And what we're putting forward in this consensus statement is an approach to how do you go, what do you start with? You reassess. If it's not healing, you go to the next level. If it's still not healing, you go to the next level. And as I explained in the introduction, the first step we see is looking at something that can disrupt or eradicate biofilm, which then enables the antimicrobial to get to the bacteria and to address the bacteria. So this is not talking about infection. This is talking about bacteria that are present in the wound but are having a negative impact on the wound itself. If we've done that and it's still not responding by our wound measurement, then the next step is to inhibit proteases in the wound, which we know are there in elevated levels and are a big component of impeding the wound healing process. And there are dressings available for that. If we've done that and it's still not improving, then we look to see what we can do to improve the wound bed specifically, and that might be by using negative pressure wound therapy or by adding a matrix substitute, or we might progress, try one, and if it's still not improved, try the other. And again, if it's still not improving, then we've got to go to the next level, and that is looking at the addition of growth factors, and there are several dressings on the market that do have growth factors incorporated into them. We don't have growth factor formulations currently on the market. They have been on the market in the past, but not presently on the market in Canada. And if they're still not healing, then we see that the problem is really the cells themselves that we know from research that sometimes it is the cells that just aren't capable of the normal proliferation. And that's where we look at adding cells, be it by skin grafts, cultured cells, skin substitutes, or even stem cells. And then we also consider other adjunctive treatments, as appropriate. And some of these might be more appropriate for different wound types, some more appropriate for venous leg ulcers, some might be brought in earlier. Some would argue things like oral pentoxifylline, might be brought in at an earlier stage. Other things we see there, electrical stimulation of the wound bed, topical oxygen therapy, hyperbaric oxygen therapy, or therapeutic ultrasound. There are others out there as well, but this is when we'd also consider, do we bring one of those in to help this wound to heal? And the final segment in the consensus statement is on what to do when the ulcer has healed. How do we prevent recurrence? So really, we're looking at lifelong compression for these patients. When the wound is first healed, we need to ensure that it is definitely healed. So we do recommend continuing the compression wraps for at least 2 weeks, and probably a little bit longer if they've got recurrent ulcers or more advanced venous disease, while we're waiting for them to get into an appropriate compression system. In most cases, we'll look at fitting compression stockings, and mostly they need to just be below the knee. But if it's not feasible, then we may look at other options like the compression wrap system with hook and loop fasteners. We're ideally looking at compression between 25 and 40 millimeters of mercury at the ankle. We may need to adjust that lower, particularly if patients have got mixed disease or if the patient simply can't tolerate higher compression. But having some form of compression is appropriate to try and reduce that risk of recurrence. We also want to encourage the calf muscle contraction exercises with a daily walking regimen, as we mentioned before. And that may involve our colleagues in physiotherapy or rehabilitation medicine. We want to reinforce the education regarding venous disease and the prevention of recurrence. So protecting the skin, the need for some form of lifelong compression, the need to replace them, and education on the exercise programs. And then we may also consider referral for venous ablation if they have just primarily superficial venous disease. Again, something that sometimes gets forgotten, but can be the key thing that will help to reduce the risk of recurrences. So that's where we're at with this. So our next steps, we've now finalized the consensus, the content of the consensus statement. We're now moving to get this published. We left a T off statement. That's my mistake. And really at this stage, certainly happy to respond to any questions, comments, or feedback. So Troy, I'll hand it back to you, but thanks very much, everyone.
Thank you so much. And maybe we'll start. I've had quite a few questions, and I'll thank Jeff, the general manager of Perfuse, been answering some of the questions as well in the Q&A box. So if you are looking at the Q&A tool, you can see some of those, but we'll cover them aloud as well. You mentioned at the end again, future considerations for other different strategies if we're not seeing some of the healing. And you mentioned E-stim at one point, or electrical stimulation at one point. Someone was just asking if you could just touch on the difference between E-stim versus the gecko. What are we looking at as a difference here?
Yeah, no, that's a really good question, Troy. And so really they're actually two very, very different technologies, if you like. They're addressing different issues and different elements. So really what E-stim does, it provides electrical stimulation into the wound bed, and it's thought that that does things to the healing process within the wound itself. So it triggers some of the positive things that can actually improve wound healing, but that's a very local, focal, addressing the issue within the wound itself. What the gecko device does is something completely different to that. It's actually activating the calf muscle pump function, so it's not doing anything directly in the wound. It's placed over the common perineal nerve on the lateral aspect of the upper calf at the top of the fibula, and it activates the calf muscle, and by doing that, it helps improve both venous and arterial blood flow in the leg. And it's that improvement of blood flow that really helps with venous and also arterial wounds. So people often get these confused because they have electrical in them and maybe stimulation in them, but actually they're two very, very different technologies.
And while we're still talking about different technologies, and one of the questions we were getting as well is whether we can use VAC or negative pressure wound therapy in conjunction with using the gecko. Yeah, no, good question. So the short answer is yes. You saw from Keith's study the gecko device can be used in combination with compression therapy. And if you're using VAC, which is just placed over the wound itself, there's no reason to not use the gecko device, which is really just activating the calf muscle pump function when patients are at rest. It's no different to what you do when you're walking. So if you can use a VAC when you're walking, you can use a VAC with gecko. Perfect, thank you. And I just noticing in the chat that there's a buzzing sound. I'm hoping I've just changed my audio input. Hopefully this sounds a little bit better, but we'll do our best on this side here. So we have a couple other questions that were coming up here. One was about compression. I know, and you were mentioning again, I've got that progressive kind of approach for those who are a little bit wary about going into compression for the first time, or if there's going to be some pain. So did you want to give any other tips or any other comments about how we should approach patients who need kind of gentle convincing of the benefits of compression therapy for managing pain? Yeah, I think it's really important to work with patients, because I think if a patient has had compression on and they've had a bad experience, no amount of talking to them is going to change their their lived experience. And I think as clinicians we need to approach that and address that and talk to them about using a lower level of compression, which causes less discomfort, less pain. And so and it might be that you have to go to really the bare minimum, as I mentioned in there, like things like just some stockinette as a starting point.
But the other thing you can do that helps if they've got pain in particular, if you're going to lower level, is then you add the muscle pump activator device, the Gecko. It can help reduce pain, but it also helps improve calf muscle pump when you can't apply full compression. And then you can sort of, as they become more comfortable, work them into one of the, what are called the light compression systems, and then work them into optimal, assuming they've got appropriate level of ankle brachial pressure indices. And you might be able to start with one of the light systems as well, depending on the patient's tolerance and compliance. But again, if you're going to a lower level, from what we've sort of come out with this consensus statement, that's an indication for using the calf muscle pump activator as well.
Thank you. And
device.
So, yeah. Right. And just to clarify again here, so I know we understand the importance of the ABPI as well, or the assessment, sorry, but is it necessary before using Gecko, or are there any risks associated with just applying the Gecko right away? I know Jeff provided some answers, but just want to make sure I get your thoughts as well.
Yeah, so no, there's no risk with applying Gecko in people with low ankle brachial pressure indices. In fact, we are working on a separate process to look at recommendations for using it in patients with, significant arterial disease. There's good evidence that it actually helps them. So definitely no evidence that it actually has a negative impact on patients with low arterial ankle brachial pressure indices.
Thank you. And we're getting a number of questions who are asking about, do we need a doctor's order? Do we need to be signed up by an NSWOCC? I know Jeff was mentioning in the chat here, and I don't know if Jeff, you wanted to come on audio as well just to address it, or if Dr. Stacey, you're able to address it as well. But lots of questions here about, is Gecko available through my prevention plan, the funding model, and do we need an NSWOCC, or sorry, can NSWOCCs order? Do we need to get a doctor sign off?
Jeff, I'll let you speak to that.
Yeah, certainly. Like the device, anybody can call up and order the device. It's used. We got the Stanley Cup going on right now, and most of the players on the teams are using a version of the Gecko device called the Firefly. The point being is that it's an incredibly low risk device with potentially high rewards. So we typically recommend that a physician is at least aware and involved, and if there's any significant health problems with the patient, the physician be consulted if enhanced blood flow is going to be an issue. Now, typically, it's 60% of blood flow of continuous walking. Therefore, the risk, generally physicians, and Dr. Stacey, I'll ask you to pipe in on this, but generally physicians encourage walking. So if we're generating 60% of the blood flow of continuous walking, then that's probably a good thing.
Yeah, no, I can certainly speak to that, Jeff. Definitely, as vascular surgeons, we encourage walking with patients with venous disease, patients with arterial disease. It does help with their not only their circulation, but it also helps with their general health as well. So certainly activity we encourage right across the board. I think the one advantage of something like the Gecko device is that it actually provides that exercise, if you like, when the patient's actually just sitting, lying, recumbent. So they're getting that benefit when they're not even actually out walking. So, and that's really probably almost certainly why in Keith's study we saw that additional improvement with Gecko plus compression, because when you've got compression on, you get the benefit when you're walking. And when you're not walking, you're getting some benefit from compression and reducing edema, etc. But when you've got compression on and you're at rest and you've got the Gecko device on, you're actually getting benefit that you would get with walking. So I think that's why we saw that increased healing rate, in Keith's study, if we want an underlying understanding of why we think that happened.
Well, and I think just adding to that, Dr. Stacey, the device is worn 12 hours a day, and 60% of the blood flow of continuous walking, that's like a 7-hour walk, right? It's like you're not getting that from well, from any patient, probably.
I should have that on when I'm sitting at my desk all day.
There you go. Well, one of the other questions or topics is surrounding lymphedema here. We had a couple questions about patients with confirmed VLU with at least biphasic pulses using the Doppler. So that's what we were covering there. But how about lymphedema? Is it safe to use Gecko as well with that in the situation with fixed ankles and no calf muscle pump action?
Yeah, I mean, I can speak to that a little bit. I mean, so I think you're asking venous leg ulcers and some lymphedema.
Sorry, I guess we're covering we've already covered the VLU. Pivoting to lymphedema, is it also impacting lymphedema?
Yeah, I mean, I can comment, and maybe Jeff has a little bit more, but I think studies, I mean, there's not a lot of studies on lymphedema alone, I think is probably the first thing to say. And still the standard of, care and lymphedema in most places would be some form of compression, maybe with, some massage therapy on top of that. But there is, some evidence from, case studies and others that using the Gecko does also help with reduce some of that edema. But Jeff, you may have more knowledge than I do on this.
Yeah, it's really we're neophytes in the area, but the point being is that we have some case studies that show a positive effect. We believe we're draining the venous system, not necessarily the lymph system. We believe that some of the major players that are dealing with lymphedema, that ideally we partner with them and demonstrate whether it does or doesn't help. We can't say for sure, but we do believe there's a possibility, but we're not making any claims.
And I'm seeing that we're at the hour here. We've got so many great questions. If we can maybe just ask one or two, and I know we'll hopefully can get through most of these here. And I think after this webinar too, there'll be ability to get in touch with Perfuse Medtec for more questions if you do want those. And I will do a little reminder at the end of where you can find out some more information. But just two more questions specifically to the consensus statement there. One was just asking about whether topical treatments were also addressed in the consensus statement.
Yeah, so I'm not sure when you say topical treatment, I mean, most of what we're looking at there was, wound dressings, which are a form of topical treatment. So they're part of that. Now, where, you might have, say, like a topical growth factor or a topical protease inhibitor, yes. I mean, we looked at general categories of treatments of the wounds, not specific products, if you like.
Yeah, that's no problem. And another question that maybe we can kind of end off of before we do some kind of final comments here is, Jeff, I know you answered some of it in the chat there. People are just asking just to repeat again about provincial coverage, or again, what's typically, depending on where someone is in Canada, what is the funding model looking like, or are they able to get some of that funding?
Yeah. Regrettably, it's postal code medicine. Which is, I don't think that's really what universal healthcare is meant to be, but it's available in about half of Ontario. It's on the formulary in BC. It's available in Nova Scotia, I believe, and we're working on other provinces. But the point being is that it's something that these patients are typically ones that cannot afford to pay on their own. It should be covered by government because we've demonstrated the economics of it, and regrettably, it is postal code medicine.
Okay. Well, thank you for touching on either way. And for the consensus statement itself, is that something that we're able to search up online, or where's the best place for us to learn more about the consensus statement?
Yeah, so that's a really good question, Troy. We're still working out where to put that. So it's not available online at the moment. We've really only just finalized it this last week or so. So we're still working out where best to house that. We'll definitely be looking at having that published. We've got a possibility of that being published in the International Wound Journal at this stage. But I think, in response to your question, one of the things we were looking at is sort of approaching some of the major wound societies like NSWOCC, possibly Wounds Canada, and, you know, even possibly having it accessible online through those, maybe something we can look at, but we haven't explored that as yet. But top priority for us to do that, though, because we want people to have it in their hands.
Absolutely, and especially on NSWOCC's perspective, we're so happy to have some great NSWOCCs on the team to help look at that as well there. So in looking for more information and as we continue that journey here, I want to remind everybody that we have actually announced another date for webinar, which will be happening next week. If you are interested in learning a little bit more, if you want to ask some more questions to Dr. Stacey that maybe we weren't able to cover today, we do encourage you to come on. We do encourage you to share that information with your colleagues. The webinar will be taking place, as I said, next week. It is going to be, if I can get it for you really, really quickly here before you all log off, it's going to be on Thursday, June 27th at the same time as now, 6 p.m. Eastern, 3 p.m. Pacific. So we do encourage you to come on and to invite your colleagues as well. So for now, we'll thank both Perfuse for being able to put this webinar on today. And thank you so much, Dr. Stacey, for sharing your expertise and your experience and your research. We're excited to learn a little bit more as we continue working alongside Perfuse and seeing more to come from the consensus statement.
Thanks very much, Troy, and thanks, Perfuse. It's been my pleasure to present this to all of you who attended. So thanks for attending, all of you, and listening.
And thank you, Jeff, as well, for coming on there. We'll look forward to seeing you next week. Have a great night, everybody.
Cheers. Take care. Bye-bye.
Okay.